All right, welcome. Today we are diving deep into the really complex world of liver pathology. We're going to explore how this absolutely crucial organ responds to, well, pretty much everything from genetic mistakes to full-blown cancer. And we're going to look at it all through the eyes of a pathologist to really understand what's happening at the cellular level. So, here's our game plan. First, we'll lay out our learning objectives, what we want to achieve today. Then we'll jump into inherited diseases, followed by the liver's response to injury like hepatitis. After that, we'll tackle the different types of liver cancer, and we'll wrap it all up by connecting the pathology back to how we actually stage and treat patients.
Okay, so Section 1. Before we really get into the nitty-gritty, let's just be crystal clear on what we want to walk away with by the end of this session.
We're going to focus on three main goals here. First, being able to recognize different disease patterns when you're looking down a microscope. Second, telling the difference between cancers that start in the liver versus those that just end up there. And finally, and this is so important, how all that knowledge directly shapes patient staging and treatment. I mean, that's really the heart of what a pathologist does.
All right, let's dive into Section 2, inherited diseases. We're going to start at the genetic level, looking at what happens when the liver's basic fundamental machinery just goes wrong, causing all sorts of toxic stuff to build up inside its cells. So, first up, we've got hemochromatosis, or simply iron overload. So think about it. In a healthy person, iron absorption is super tightly controlled. But here, that whole system just breaks down. The body starts absorbing way too much iron from your food, and since there's no good way to get rid of it, it just starts to pile up, mostly inside the liver cells, the hepatocytes. And this is where we get to use one of the pathologist's classic tools. To be sure about the diagnosis, we use a special stain called Pearl's Prussian blue. It reacts with any iron deposits and turns them this really brilliant, unmistakable blue. It just pops right out when you're looking under the microscope, making it very clear what's going on. Okay, next up is Wilson's disease. It's a similar idea, a storage problem. But this time, the culprit isn't iron, it's copper. It's another genetic disorder where the body just can't get rid of copper properly. So, just like with the iron, it starts to build up in tissues, and the two main targets are the liver and the brain.
But the real problem, the real danger here, is what that buildup actually does. You see, too much copper is toxic. It kicks off this chronic inflammation that just never quits. And over time, that constant battle leads to scarring, what we call fibrosis, which can eventually snowball into cirrhosis. And that's a really severe, irreversible stage of liver damage. And just like with iron, we have a special stain, the Rodinin method, to light up the copper and confirm the diagnosis.
Okay, our third inherited condition is alpha-1 antitrypsin deficiency, or AAT for short. Now, AAT is a really important protein. Think of it as a bodyguard. Its main job is to protect our tissues, especially in the lungs and liver, from getting chewed up by enzymes that get released during inflammation. With this condition, you just don't have enough of this bodyguard protein.
And not having enough of this bodyguard protein, well, that has a huge impact across the body. In the lungs, without that protection, the delicate structures get damaged, and that leads to emphysema, often at a really young age. At the same time, in the liver, the defective AAT protein gets stuck and builds up, causing damage, sparking that chronic inflammation, and putting the person at a much higher risk for cirrhosis.
So we've covered how things can go wrong at a genetic level. Now let's move on to Section 3 and look at how the liver responds to more direct external injuries. We're going to focus on two of the most common reactions: inflammation, which is hepatitis, and the buildup of fat.
Okay, it is absolutely critical to understand the difference between acute and chronic hepatitis. Acute is a sudden, rapid onset event. It's caused by things like the hepatitis A virus, or maybe a toxic dose of a drug. Under the microscope, you see what we call spotty necrosis, basically individual liver cells just dying off here and there. But chronic hepatitis, that's a different beast. We define it as inflammation that lasts longer than 6 months. It's often driven by viruses like Hep B and C, and the real danger is that this relentless inflammation slowly but surely leads to scarring or fibrosis, and ultimately cirrhosis.
Now look at this. This is how we can pinpoint the exact cause with incredible precision. This isn't just any old stain. This is called immunohistochemistry. Basically, we're using these specially designed antibodies that act like little heat-seeking missiles. They will only lock onto specific viral proteins. So every single one of those brown cells you see, that's a liver cell that's been infected. It's definitive proof.
All right,
The other major way the liver reacts to injury is something called steatosis, which you've probably heard of as fatty liver disease. And it is exactly what it sounds like. It's the buildup of fat, triglycerides to be specific, inside the liver cells. And it is an incredibly common finding linked to everything from alcohol use to obesity and metabolic syndrome.
And this slide, wow, this is a picture-perfect example of what that looks like. This is called macrovesicular steatosis. You can see these big, clear, round bubbles inside the liver cells. Those are fat droplets, and they've gotten so big that they're literally shoving the cell's nucleus all the way over to the edge. This is the classic textbook appearance of fatty liver disease.
Okay, so we've seen how injury and inflammation can really beat up the liver. That brings us to section 4, where we're going to talk about the most serious outcome of all that damage, cancer. And it's absolutely essential here to distinguish between cancers that start in the liver and those that just spread to it from somewhere else.
The absolute #1 distinction you have to make is where the tumor came from. Primary tumors are ones that grow from the liver's own tissues, like hepatocellular carcinoma, which comes from hepatocytes, or cholangiocarcinoma from the bile ducts. But, and this is a key point, what we actually see far more often are secondary or metastatic tumors. These are the cancers that started somewhere else in the body and then traveled to the liver.
And these two images right here show that difference perfectly. On the left, you've got the macroscopic view, what a surgeon would see in the operating room. See all those different sized tumor nodules? That cannonball appearance is classic for metastatic disease. Then on the right, we've zoomed way in to the microscopic level. You can see these clusters of angry-looking, dark purple malignant cells just infiltrating and taking over the normal, healthier pink liver tissue.
So why the liver? Well, think about it. The liver has this massive blood supply. It's like Grand Central Station for the body's circulation. So it's a really common place for cancer cells traveling in the blood to set up shop. Cancers from the GI tract, like colon or pancreas, often go there first because of the blood flow. But as you can see, lung cancer, breast cancer, and even melanoma also frequently spread to the liver.
Okay, so a pathologist has identified a malignancy. Now what? Where do we go from here? Well, that takes us right into Section 5, Staging and Treatment, because the pathologist's report is absolutely fundamental. It directly tells the oncology team how to stage the cancer and build a treatment plan.
What you're looking at here is the Barcelona Clinic Liver Cancer Staging System, or BCLC. This is pretty much the gold standard for hepatocytocarcinoma. And what's so powerful about it is that it doesn't just look at the tumor. It pulls together multiple factors. The size and number of tumors, sure, but also the health of the rest of the liver and the patient's overall well-being. And you can see how that directly guides treatment. A tiny, early tumor might mean curative surgery. But as the disease gets more advanced, the options shift towards things like TEAS to choke off the tumor's blood supply or systemic drugs for widespread disease.
So this really lays out how the entire philosophy of treatment shifts depending on the stage. In the very early stages, the goal is a cure. We're talking about completely removing the cancer, with 5-year survival rates over 60%. For intermediate disease, the focus changes to controlling the tumor's growth. But by the time we get to the advanced stage, when the cancer's invaded blood vessels are spread, the goal becomes palliative, slowing the cancer down and managing symptoms with targeted therapies.
All right, let's bring this all together in our final section. We've gone all the way from single gene defects to inflammation and finally to cancer. So what's the big idea? What's the thread that ties all of this together?
Okay, if you remember just one thing from this whole discussion, let it be this. Chronic inflammation is the engine that drives liver cancer. It really doesn't matter what caused the initial damage, a virus, alcohol, fat buildup. That persistent long-term inflammation leads to scarring, to fibrosis. And a scarred, cirrhotic liver is the perfect breeding ground for cancer. The constant cycle of cell death and regeneration creates genetic instability, which dramatically raises the risk that one of those cells will mutate and turn malignant. This is the crucial inflammation, fibrosis, carcinoma sequence.
And that brings us to a final forward-looking question. You know, for more than 100 years, pathology has been all about what we can see under a microscope. But we are squarely in the molecular era now. The future of liver pathology isn't just about shapes and colors, it's about sequencing tumors to find their specific genetic drivers. So the real question for the next generation of pathologists and oncologists is this: how are we going to weave all this complex molecular data into our plans to create truly personalized treatments? Treatments that go way beyond what the microscope alone can show us?